Supply to the gut, which are the celiac, the superior mesenteric, and the inferior mesenteric artery. Okay, the blood that comes from these arteries to the gut is usually returned back through, which we call it portal circulation. Okay, where there is a portal vein that formed behind the neck of the pancreas, and it drains into the liver for filtration of this blood. So we will move now to the start of this story, to the arterial supply. Okay, so we spoke in this story in a vice versa. Start speaking about blood supply. If we speak generally about blood supply in the abdomen, whether abdominal wall or abdominal viscera, okay, in the cavity, okay, it's mostly come from the abdominal aorta, which is the main blood supply to the abdomen. Okay, the abdominal aorta starts at the hiatus, okay, which form behind. Okay, then they consider it, that's why a hiatus, behind the diaphragm. So it's an opening, but it's behind the diaphragm. The posterior border of this opening is the lumbar or T12 vertebra. So it's opposite to what? To T12. Move down to the lower part of L4. Sometimes at the disc between L4 and L5, it ends bifurcating into 3 branches actually, not 2. It gives 3 branches. 2 main ones, the 2 common iliacs, and one that pass at the middle of the sacrum anteriorly, providing blood supply to the sacrum. We call it median sacral. Okay, so 2 common iliacs and median sacral. If we're going to speak about the branches in general of the abdominal aorta, we follow the rule of 3. Okay, rule of 3, that means there are 3 arteries that's going to go laterally. I'm speaking now within the abdominal cavity, not the abdominal wall, because in the abdominal wall, from the posterolateral corner of the abdominal aorta, mostly posterior, there will be lumbar arteries, okay? 1, 2, 3, 4, and 5. You see them? 5 lumbar arteries that will go to supply the abdominal wall, okay? However, the first lumbar now, there is a variation in anatomy books. The first one will not move along the posterior abdominal wall, then lateral abdominal wall, okay? So the first lumbar instead will go into the inferior surface of the diaphragm, the roof, okay? So this one will be called inferior. The adjective for diaphragm is phrenic. So it is the inferior phrenic artery. So in some anatomical books, you will see that there are 5 lumbar arteries. In others, you will see there are 4. But the other one is not lumbar. They will call it inferior phrenic. So whether you have an inferior phrenic and 4 lumbars, okay, the 4 lumbars will be to the posterior and lateral abdominal walls, okay? So what is for anterior abdominal wall? The epigastrics, superior and inferior, if you still remember them, okay? And superficial epigastric, 3 epigastrics. So whether you have 4 lumbars, that's fine, or whether you have 5 lumbars and the first one is called inferior phrenic. So branches, we have abdominal wall branches, okay, which will go to where? The abdominal wall branches to the posterior and lateral abdominal wall. And there is one to the roof, which is the inferior phrenic artery. Now, abdominal cavity branches, or branches to the viscera now, those are the rule of 3. You will have 1, 2, and the 3 arteries that goes laterally. So from the lateral aspect now, not posterior, not posterolateral corner, from lateral, you will have 3 branches. 1 to the suprarenal gland, 1 to the kidney, renal, so the suprarenal will be called suprarenal artery. To the kidney we will call it renal, and 1 to the gonads, whether ovaries or testes. It will be ovarian or testicular, or in general gonadal, okay? So we will have a gonadal artery. So 3 lateral branches, we don't concern about these because they are not related to the GI system, okay? You will fulfill these in the urogenital system, okay? But just remember, if we speak about the abdominal aorta, 5 lumbars, okay, and the rule of 3 inside. We have 3 laterals, 3 anteriors, and 3 terminations. The 3 terminations, we spoke about them. The 2 common iliacs and this one in the middle, median sacral. It's on the sacral, okay? So the median sacral. So we have 2 common iliacs and median sacral. What about the 3 anterior ones now? Yes, those are the ones which are going to develop along with the development of the gut. The celiac, the superior mesenteric, and inferior mesenteric. And as you know that, the gut develops usually from 3 main parts. The foregut superiorly, the mid gut in the middle, hind gut at the lower part. As it develops, these three arteries will develop with each one. So the artery for the foregut is the celiac trunk. Okay? The artery for the midgut, superior mesenteric, and for the hindgut, inferior mesenteric. Okay? Now, if you know the points of effusion, as I told you in the lab, the points of merging between the foregut and midgut and hindgut, you will know the main source of blood supply to these viscera. Okay? So the foregut is fused with the midgut where? In the second part of the duodenum. Yes? At the major duodenal papilla. Okay? Where the ampulla of Vater is opening. At the major duodenal papilla. So the part of the duodenum above is from the foregut. The part of the duodenum below is from the midgut. Okay? Since the part of the duodenum above is from the foregut, it is supplied by the celiac. Okay? The one below from the superior mesenteric. So the other point of effusion now between midgut and hindgut, it is the proximal 2/3 of transverse colon and distal third of transverse colon. So the proximal 2/3 from where? The midgut with distal third hindgut. Good. So now the blood supply of the midgut is the superior mesenteric. By this, the proximal 2/3 from the midgut receive their blood supply from superior mesenteric, while the distal third from the inferior mesenteric, which is the artery for the hindgut. So now if I follow the gut or the abdominal viscera from up to down, I have the abdominal part of esophagus, the stomach, the upper part of duodenum until the major duodenal papilla. Those three from the foregut. So they receive their blood supply from the celiac trunk. So if I told you abdominal esophagus, it's celiac. Stomach, celiac trunk. Upper part of the duodenum, celiac trunk. Okay? Now, very important there, the level of transverse colon is dividing the abdominal cavity into two compartments, a superior and inferior. Because if you look below the transverse colon, there is nothing more than intestine, whether small or large. So this is, we will call it the infracolic compartment. The part above the transverse colon is called supracolic compartment. And in this part you will see the stomach, abdominal esophagus, and the accessory organs, the liver, gallbladder, pancreas, and a lymphatic organ, which is the spleen. Now, celiac usually, since it provides blood supply to the foregut, which is located where? In the supracolic compartment. So the celiac also will supply these organs. So if I ask you, what does the celiac trunk supply? It supplies the foregut and the viscera in the supracolic compartment. Because celiac artery is in the supracolic compartment. Okay? Cool. So the first one is the celiac. It provides blood supply then to the liver, to the gallbladder, to the pancreas, to the spleen, and abdominal esophagus, stomach, upper part of duodenum. Now we move to the midgut. The artery of the midgut is superior mesenteric. Okay? The superior mesenteric. It should supply what? The lower part of duodenum, the jejunum, the ileum, the cecum and appendix, the ascending colon, proximal 2/3 of transverse. Good. Now the hindgut, which artery there? Inferior mesenteric. It must supply the distal third of transverse colon. What's after that? Descending colon, sigmoid and rectum. Okay? Sigmoid and rectum. So this is the basic story for these blood supply. If we go in more details now, let's start with the celiac trunk. Celiac, it's actually from the word coeliac. So you see sometimes in British they write CO, okay? Because it was pronounced in the Greek coeliac. Coeliac means the belly, okay? The abdomen, okay? That's where the origin of the name, the celiac trunk. It's usually located, as you see here. Once the abdominal aorta leaves the aortic hiatus, okay, once it leaves the aortic hiatus down below the diaphragm, it will give the celiac. The celiac, which is very short, okay, around 1.2 centimeters, okay, or 1.2 to 1.3 centimeter in length, but it's very wide. Why it's very wide? Because it's later on will divide into one branch goes to the right side, the other branch will go to the left side, and a small branch that will loop on the lesser curvature of the stomach. So the celiac in general will divide into 3 main branches. Okay? These 3 main branches related to the suprapubic structures. Okay? The first one, which will go to the right, by common sense, it will supply to the liver, which is located in the right, liver and gallbladder. Okay? So this will be called the common hepatic. Okay? The one which will go to the left, behind the stomach, you see, to reach to the spleen, it's the splenic artery. This is the largest branch of celiac. Okay? By the way, splenic is the largest. Yes, it's written. So we have common hepatic, we have splenic, and we have a small artery that will go up, okay, you see here, until the gastroesophageal junction. Then it will loop. Loop يعني بيعمل U-turn and descends down on the lesser curvature of the stomach. On the left side, we would call it left gastric. Now, as a shortcut before we continue, you have to know that when we speak about blood supply to the stomach, we have 5 main arteries, okay, or 5 main kinds of arteries. On the lesser curvature of the stomach, you need 2 arteries. One going from the left side, the other one here, coming from the right side. Those 2 will unite at the level of angularis incisure, okay? So 2 arteries at the lesser curvature. And we need another 2 where? At the greater curvature of the stomach. Those are 4. Those 4 main arteries, the ones on the lesser curvature, to distinguish them from the ones on the greater curvature, I will give them a lesser name. So the ones on the lesser curvature, I will call them gastric arteries. The ones on the greater curvature, since they pass within the 2 layers of omentum, okay, the greater omentum, I will call them gastro-omental or gastro-epiploic, okay, the gastro-epiploic arteries. So gastro-epiploic or gastro-omental arteries. So to distinguish them, if you hear the word gastric alone, it's on the lesser curvature. Gastro-omental or epiploic, 2 words, it's on the greater curvature. The ones on the lesser curvature, one comes to the left side of the stomach, we will call it left gastric. The other one, as you see, goes on the right side. I would call it right gastric. Okay? The left gastric arrives directly from the celiac, as you see, and loops on the lesser curvature on the left side. While the right gastric, watch this artery, we agree? Common hepatic. So the right gastric comes from where? From the common hepatic. It makes sense, because since it's going to go to the right side of the stomach, it needs to wait a little bit until the artery that's moving to the right, which is the common hepatic, passed until the right border of the stomach, then it will come, okay, to be on the right side. So we have right gastric from the common hepatic and left gastric from where? From the celiac. What about those 2? Gastroepiploics. Well, the left gastroepiploic is from the splenic, while this one, the right, we will speak about it when we reach it. But I want you to remember we have 4 arteries now. Where is the 5th? The short gastrics or the fundic arteries, okay, which come also from the splenic before it enters into the spleen to supply the fundus. That's why they call them short gastric, because they are very short, or they call them fundic arteries, okay? Fundic or short gastric. So, back again to the celiac. The first branch of the celiac is, as I told you, the splenic now. Okay, this is much easier. It's the largest branch of the celiac trunk. Okay, it passes, as you see, over the body of the pancreas and behind the stomach. This is the shadow or the bed for the stomach, where the stomach is leaving. Okay, so it passes posterior to the stomach. Okay, behind the stomach. Okay, and superior to the pancreas. So it is retroperitoneal. Remember this. Okay, it's superior. As it passes above the pancreas here, it will provide several branches to the body of the pancreas. So this providing main blood supply to the pancreas. Okay, the splenic artery. Okay. It enters which ligament now? Since it's retroperitoneal, it needs to go to the pancreas. It needs to go, to the spleen. Okay? Splenico-renal. Do you remember when we spoke here, we have this ligament and this ligament. We said this is the gastrosplenic, which is part of, yes, greater omentum. But this one, which connects the spleen with the posterior abdominal wall, splenico-renal. This is the aorta. Celiac trunk will come from here. We'll give the splenic, which will pass over the pancreas here and get through this ligament into the spleen. Once it gets there, it will give now a branch that goes up to the fundus, and another one will go down on the lateral curvature within this ligament, okay, which is the greater omentum, okay, before it gets into the spleen. So this is the pathway for the splenic, okay. Before it enters here, it will give branches to the stomach through this ligament, okay. So it passes through splenico-renal, okay, ligament. So it enters the splenico-renal ligament to reach the hilum of the spleen. The branches, it will give, as I told you, pancreatic arteries to the pancreas. Okay? It will give short gastric arteries where? To the fundus, and the left gastroepiploid, which we saw it here, this one. Okay? To the greater curvature of the stomach. The hepatic now. Let's speak about the hepatic. You see here, this is the celiac, splenic, left gastric, and all of this is the hepatic. Now the hepatic, once it arrives, since it's very large, we will call it the common hepatic artery. Okay? As it passes, it will give first a branch. Which branch is this? The right gastric artery, which will anastomose with this one, with the left gastric, when it loads. Okay? Then, once it's behind the first part of the duodenum, it will send an artery below, behind the first part of the duodenum. This artery will go to supply the stomach and the duodenum. So we will call it gastroduodenal artery. Okay? So it will give right gastric artery where? To the lesser curvature of the stomach. It anastomoses with, you see, on the lesser curvature, it anastomoses with the left gastric. Then it will give this branch, as you see. Now this branch, شايفينه, behind the first part of the duodenum. Okay? We would call it gastroduodenal. Why we call it gastroduodenal? Because it's going to supply the stomach and the duodenum. At the lower part, once it leaves the first part of the duodenum, below the first part of the duodenum now, once it comes down, it will give the right gastroepiploid. Okay? It will give the right gastroepiploic artery, as you see. Okay? So this now, we will call it the right gastroepiploid. What about this one? This one will pass in the concavity between the duodenum and the pancreas, because duodenum C-shaped, the head of the pancreas is there. So this one will pass in the groove between them. I would call it superior pancreatico from the pancreas duodenal artery. Superior pancreatico-duodenal artery, which will supply only the duodenum only to the major duodenal papilla. ليش؟ لأنه هنا بتنتهي الفورغات. Okay? So it will pass along in the groove between the duodenum and the pancreas till the level of major duodenal papilla. Then it will anastomose with another one called inferior this time, pancreatico-duodenal. Where does it come from? From the superior mesenteric, because it's a midgut. Okay? So now, common hepatic first will give the right gastric. Continue to give gastroduodenal. The gastroduodenal will descend behind the first part of the duodenum, and below the duodenum now, the first part, of course, will divide into the right gastroepiploic and the superior pancreatico-duodenal. Okay? Now, after this, the common hepatic will be called the hepatic proper artery, or the main hepatic artery. Okay? To distinguish between the point of branching of the gastroduodenal. Before the gastroduodenal, it is common hepatic. After the gastroduodenal, it's hepatic proper, or the main hepatic artery. Okay? And we'll continue the hepatic proper, or the main hepatic, until where? Until the porta hepatis, or the hilum of the liver, where it will branch into left and right hepatic arteries. Now, we need an artery for what there? For the gallbladder. Yes? Since the gallbladder is cyst, this artery will be called cystic artery. Where it should come from? From the left branch or the right branch, you think? Right, most of the time. Okay, most of the time, because there is variations. It comes from the right branch. Why? Because it is in the right side. Okay? The gallbladder is on the right side. So, cystic artery comes from the right hepatic artery. So this is the story again. Common hepatic, first it will give the right gastric, then gastroduodenal, which will descend into right gastroepiploic and superior pancreatico-duodenal. Then it will become hepatic proper, which will give right and left branches. These are the branches for the celiac. Again, you can go over them by yourself. But what about the superior mesenteric now? This one. You see, this is the celiac, this is the superior mesenteric. The superior mesenteric arises below the celiac trunk. Just above what? The left renal vein. You see now, if you remember on the cadaver, for the ones who I gave them a demonstration, I show you that the left renal vein is what? Is trapped between two arteries, the superior mesenteric anteriorly and the abdominal aorta. If you remember that on the cadaver, you saw that the left renal is trapped there. So this is very important relation. Behind the left renal vein is the abdominal aorta. Anterior to it is the superior mesenteric, because the superior arises just from above it and descends anterior to it. Okay, so it's trapped now between these two arteries. In cases you have an increase in arterial blood pressure, okay, or dilatation in one of these, mainly the aorta, triple A we call it, abdominal aortic aneurysm. In cases of aneurysm, this will provide the pressure on what? On the left renal vein. And you know that the wall of the vein is much weaker because less tonica media, okay, than the wall of the artery. This will lead to what? To collapse or blockage in the left renal vein. So blood starts to accumulate where? In the left kidney, because there is no proper venous drainage. Okay? In this case, it may lead to what? To left renal failure. But if you have only on one side left renal failure, but not the right side, so basically the problem is not the kidney. The problem is vasculature. Okay? You have to check for this relationship. So remember this. Why this relationship is important? Because it could affect what? The left kidney, okay? Function. So remember this relationship. It's just above, then it goes anterior. Above, then anterior. Add it, please. Then anterior to the left renal vein. It descends posterior to the neck of the pancreas. If you look, it's going, this is the relationship. You see, this is the aorta, this is the superior mesenteric, this is the left renal vein. If you look here, you will see that the superior mesenteric is passing behind the neck of the pancreas. So it's behind the pancreas. Okay, so it's retroperitoneal first. Then below the pancreas now, it will move anterior to third part of duodenum, as you see, where now it will go into the mesentery, inside the peritoneum. Okay, it enters the peritoneum. So it passes first behind the neck of the pancreas, then anterior to what? To the duodenum. Okay, so it descends posterior to the neck of the pancreas, then anterior to the third part of the duodenum. هاي البنكرياس تحكي في الديودينم بنزل، اوكي، هون الديودينم سي شيب والبنكرياس عليه، هو بنزل بيهايند، بعدين هون الثيرد بارت هولا بنزل بيطلع بين البنكرياس والديودينم، بيطلع من بينهم وبيروح للايش؟ into the peritoneum، اوكي؟ into the peritoneum. It supplies the intestine. شوفوا من وين؟ من اللور بارت of the duodenum، مش شرط half، almost half، اوكي؟ from the lower part of the duodenum، يعني من الميجر duodenal babilla below، لأنها بداية المدقط، until the proximal 2/3 of transverse colon، بغذيهم طبعا، الديستال third ما بغذيهم، اللي هو المدقط artery. الآن خلنا نشوف شو البرانشز تاعيته. لما بنحكي على البرانشز تاعيته، قبل ما نحكي على الهاي، كم بارت عندنا المدقط؟ خلنا نعدهم. lower part of duodenum 1، jejunum 2، ileum 3، cecum and appendix 4، okay? ascending colon 5, proximal 2/3 of transverse colon 6. So we have 6 parts of the midgut. So how many branches I need from the superior mesenteric? I need 6 branches. Okay? For each one. Lower part of duodenum I need a branch. Okay? Jejunum I need branches. Ileum branches. Cecum and appendix I need branches. Okay? Like this. 6 branches. The first one I told you about, inferior pancreaticoduodenal artery. Okay? Why you think we need it? You see it? It's here, retroperitoneally by the way, before, okay? قبل ما يدخل في البريتونيوم. لسه ورا البنكرياس. لما يجي يطلع شايفينه؟ This is the duodenum anterior. Just before it rises anterior to the duodenum, it will give it. This one will go up and merge or anastomose with another artery. Superior pancreaticoduodenal. اللي هو من وين؟ من الجاستروديودينال، اللي من الكومون هيباتيك، من السيلياك. So they will merge at the level of the major duodenal. So أول واحد inferior pancreaticoduodenal artery. Why I need it? to the lower part of duodenum. Then you will have several branches where? To the jejunal branches. بعدين to the ileal branches. Then a branch to the cecum and appendix. Okay? This is it. It goes to the cecum and appendix. I will call it ileocolic. Because it's not to the cecum only, to the appendix only. Two parts of the large intestine. So it's not ileocecal. Remember this, it's ileocolic, to the colon. Okay? So we will call it the ileocolic artery. Okay? Ileocolic artery now, if you want more details to get into, ileocolic, it's called ileocolic because it will supply the terminal part of ileum, the appendix, the cecum, and small part of the ascending colon. Okay, that's why we call it ileocolic. Ileocolic will divide it, as you see here, once it ends into 4 branches. One will go up to unite with the right colic. The right colic, this is after ileocolic, from the superior mesenteric. ليش اسمه right colic? It goes to the right. What's there? The ascending colon. Now, however, the ileocolic, once it reaches to the border on the lower right corner, the first branch, we will call it the ascending branch. This ascending branch, as you see, anastomosed with what? With the right colic. So it helps in supplying part of the ascending colon. Okay? It will give a descending branch. The descending branch will loop to anastomose with what? With the superior mesenteric itself. It anastomoses with the superior mesenteric itself. That's why they call it, this is the terminal branch, or the terminator of the superior mesenteric. It loops to anastomose with the superior mesenteric itself. So we have an ascending branch. Helps with the ascending colon, okay? Helps to anastomose with the right colic. A descending branch will anastomose with what? With the superior mesenteric itself. We have 2 branches, one anterior, one posterior. Now those will go to the cecum. One will supply the cecum from its anterior surface, the other one from the posterior surface. What would I call them? Anterior cecal now, and behind posterior cecal. Do you know now why we distinguish ileocolic, not ileocecal? Okay? So the ileocolic will be branching into one superior, one inferior, one anterior, one posterior. The superior will merge with right colic. الانفيرير مع ايش؟ إذا إجاك سؤال وين بيعمل ميرجينج أو أنستوموسيس؟ مع السوبيريور ميزنتريك نفسه. Okay? The one anterior and posterior to the cecum, anterior cecal, posterior cecal. One of these two will give a branch to the appendix. I would call it the appendicular artery. Which one you think? Posterior. Why? Because of the position of the appendix. It's retrocecal. So the posterior cecal will give the appendicular artery. Okay? Clear? والله اجى السنة الماضية مش راح اجيب السنة. So the appendicular artery is a branch from the posterior cecal, which is a branch from ileocolic, which is a terminal branch of superior mesenteric. Okay? So superior mesenteric الآن اتفقنا inferior pancreaticoduodenal لوين؟ لlower part of duodenum. Jejunal branches وإليال branches والإليوكوليك. Okay? بعدين الرايت كوليك حكينا ليش رايت كوليك؟ To the ascending colon. Okay? In the right side. بعدين في واحد شايفينه بالنص هو فعليا to know the story it goes just in the middle anterior like this. If you look to this view شوفوا هاي الفيو شايفين السوبيريور ميزنتريك you see this artery here هذا راح يجي ويمشي في الترانسفيرس ميزوكولون to this structure which is شو هذا الترانسفيرس كولون شوفوا كيف بيجي بيطلع anterior in the middle وبيمشي هون في الترانسفيرس ميزوكولون until it reaches the transverse colon. This we will call it now middle colic, to the middle part of the colon. We call it transverse colon. Middle colic artery, okay? So the middle colic now, هاي شايفينه بيطلع and it what divides to supply what the proximal 2/3 of transverse colon. This will be called middle colic. So now I have 6 branches. شو هم؟ Inferior pancreaticoduodenal, jejunal, ileal, ileocolic, right colic, middle colic للproximal 2/3 of transverse colon. يعني لو أسألكم superior mesenteric branches شو اللي بيغذي lower part of duodenum؟ هاي أنتم بتقدروا تعبيها inferior طيب والجيجينم والإيليا ileocecal valve وسيكم وابندكس ileocolic. يعني لو أسألكم شو اللي بيغذي ileocecal valve is ileocolic. ascending colon right colic. Proximal 2/3 middle colic. الانفيرير ميزنتريك ناو من وين بيبدا؟ من الديستال ثيرد ترانسفيرس كوليك. اكبر برانش شفتوه بالانجيوجرام باللاب اللي هو بسميه ليفت كوليك ارتري، صح؟ ليش ليفت كوليك؟ Because it goes to the left side as you see. The left colic branch goes to the left side, okay? Supplying the distal third transverse colon. عشان هيك له branch بيطلع superiorly بالأعلى to the distal third transverse colon and descending colon, okay? Then you will have sigmoidal arteries with termination شو هو بيكون؟ superior rectal to the rectum, okay? The superior rectal artery. It runs downward to the left after it crosses ماشي the inferior common iliac artery, okay? The left common iliac. هاي يعني شايفينه الانفيرير ميزنتريك؟ This here now هذا left common iliac. This branch here will become what? Superior rectal artery اللي هو terminal branch of inferior mesenteric. شو terminal branch من السوبيريور؟ Iliocolic. Remember this, iliocolic. Okay? But here it is this one, the superior rectal. على level of the left common iliac. left colic. اوكي اتفقنا الليفت كوليك شايفين بيبدا من الديستال تير وبنزل بعدين شو بيعطي؟ sigmoidal branches 2 to 3 2 to 4 sometimes, okay? Branches to the sigmoid or superior rectal, which is the continuation of the inferior mesenteric. It goes behind the rectum, supplies. شوفوا شو بيغذي السوبيريور rectal الان. مشان بدي احكي شوي على الانستوموسيس. supplies الريكتم كله. والريكتم لما بيضيق شو قلنا بصير؟ anal canal, okay? And the upper half of the anal canal. إذا بدكم حتى الصح غيروها. شو upper 2/3 of the anal canal, okay? The upper part or upper 2/3 of anal canal. لأنه الهايند gut بتنتهي هناك. في الupper 2/3 of the anal canal. اللور third من وين جاي؟ proctodia, صح؟ And merge together. لما يعملوا merging بين الupper 2/3 والlower third of the anal canal هذا هو البكتينيت لاين. أو بالهيستولوجي بنسميه recto-anal junction, okay? The recto-anal junction, but it's not a junction between the rectum, it's within the anal or pectinate line. So upper 2/3 of the anal canal. هون عند البكتينيت line أو عند recto-anal junction بين upper 2/3 of the anal canal والlower third بصير anastomosis بين superior rectal وanother 2 arteries اللي بيغذوا lower third of anal canal بالبلبس اللي هم middle rectal وانفيريور ريكتال، اوكي؟ ارتريز اذا سمعتوا فيهم، هذول جايات من وين؟ من الانترنال ايلياك ارتري، اوكي؟ اللي هو جزء من الكومون يعني من السيستميك سيركوليشن. لان this blood from the superior rectal, middle rectal, inferior rectal arteries عند الليفل اوف بكتينيت لاين will return through venous circulation اما لسوبيريور ريكتال فين للانفيريور ميزنتريك او في الميدل والانفيريور ريكتال فينز للانترنال ايلياك. اللي بيروح للانفيريور ميزنتريك راح يروح للبورتال سيركوليشن، واللي بيروح مع الانترنال اريا للكيفال اور ذا سيستميك سيركوليشن. when there is portal hypertension اذا ذاكرين شو بيصير عند البكتينيت لاين؟ هيمورويدز بسبب هذا. الابدومينال ايورتيك انيوريزم تريبل اي بيصير localized dilatation ballooning of the abdominal aorta. اوكي؟ يعني بيصير اكثر من 50%. اوكي؟ يعني 1.5 ضعف الديامتر of the aorta. اوكي؟ most of the time it happened infrarenal. اوكي؟ شو يعني infrarenal؟ below the renal arteries. اوكي؟ risk factors in all people due to degeneration of tunica media. Yes, and the elastin. The risk factors اللي هم الهايبرتنشن، السموكينج، المورفا دير. asymptomatic but major complications is rupture. عشان هو هيك هو life threatening. ما بيكون المريض داري فيه، يكتشفوه عادة بالصدفة. اوكي؟ فإذا صار فيه rupture it's what an emergency situation, a life threatening condition. وين
divided into 4 parts: the ascending aorta, aortic arch, thoracic aorta, and the abdominal aorta. The abdominal aorta is the last and largest section of the aorta. It supplies blood to the lower regions of your body, including the organs in the abdomen and pelvis. The abdominal aorta ends around navel level, where it splits into the 2 iliac arteries that carry blood to the legs. The aorta has a thick wall so it can withstand the high pressure of blood being pumped from the heart. Over time, the wall of the aorta may weaken, slowly bulging outward like a balloon. When this condition occurs in the abdominal region, it is called an abdominal aortic aneurysm. Your surgeon will perform an open abdominal aortic aneurysm repair when the diameter of your aorta exceeds 2 inches, or if you're having symptoms such as intense abdominal pain or an abnormally prominent abdominal pulsation. Before the open procedure, an IV line will be started to provide you with fluids, antibiotics, and anesthesia. A traditional open surgical repair is performed under general anesthesia, which means you will be asleep for the duration of the procedure. A breathing tube will be inserted through your mouth and into your windpipe to help you breathe during the operation. When you are asleep, a catheter will be inserted into your bladder to drain your urine and monitor your kidney function. Your surgeon will begin by making an incision from the breastbone to below the navel. He or she will then locate the aneurysm and clamp the aorta just above and below it. Your surgeon will then open the aneurysm and sew an artificial graft the same size and shape as a healthy aorta into place. Your surgeon will stitch the wall of the aneurysm closed over the newly placed graft. The graft will reinforce the walls of the aorta. Your surgeon will close the abdominal incision with stitches. The total length of this procedure is usually 4 to 6 hours. Your surgeon will perform endovascular aneurysm repair, a newer, minimally invasive procedure if you have severe heart disease or are at increased surgical risk due to age or other medical conditions. Before the endovascular procedure, as with the open procedure, an IV line will be started to provide you with fluids and antibiotics. You may receive general anesthesia, or you may receive a sedative and an epidural or regional anesthesia to numb only the lower half of your body. Your surgeon will begin by making a small incision in your groin over your femoral artery. Then he or she will insert a guide wire into the artery and gently push it up toward the site of your aneurysm. A catheter or hollow tube will be passed over the guide wire and pushed toward your aneurysm. Using live X-ray pictures as a guide, your surgeon will pass an endovascular stent graft, a compressed fabric and metal tube, through the catheter to the aneurysm. Then he or she will open the graft, which will be held in place with metallic hooks and stents. Your surgeon may insert additional graft components to extend the graft into the blood vessels supplying your legs. Once the graft is in place, your blood will flow through it, not into the surrounding aneurysm sac, which will remove the pressure from your aneurysm. Finally, your surgeon will remove the catheters and close the incisions in your groin. The procedure will generally take 2 to 3 hours. After your procedure, if you had a breathing tube, it will be removed, and you will be taken to the intensive care unit for recovery. You will receive fluids and nutrition through your IV. You may also have a tube inserted through your nose and into your stomach to remove secretions until your intestines regain normal functioning. The usual hospital stay for an open procedure is 5 to 10 days, while the stay for an endovascular procedure is usually shorter at 2 to 3 days.
So this is the story of the triple A. يعطيكم ألف عافية.